My conversation when I see a patient that comes in for the first bout of congestive heart failure, I will say to people, yep, we're going to manage this. We're going to buy your animal healthy time, but it's going to be the thing that's going to kill it. Does this change that conversation?
Absolutely.
My introduction for this one is going to be brief because you know the story. You get that dog in front of you with a heart murmur and it's starting to go into congestive heart failure, and you know that this is probably the beginning of the end for that patient. Yeah, you're going to manage it and you're going to keep it happy for months, maybe a couple of years if things go really well, but we all know where this ends. Until now, there are some amazing things happening in the world of veterinary cardiology, and I don't want to spoil the whole episode by telling you too much about the TEER procedure right now, although we've kind of given away the end in the title there, haven't we? But you do need to know the details, and you definitely want to hear about the how, because it's paradigm shifting and it's so freaking cool. So before you consign your next congestive heart failure dog to the soon-to-be deceased pile, have a listen to this and share it with a colleague who might not know about it yet. Now, a quick caveat on this one. This is obviously not a how to do the TEER procedure in your practice episode. There is a way that you can learn to do it that's really actually quite straightforward with the right amount of time. You go and you specialize in veterinary cardiology, and then you work for a number of years, maybe 5 or 10 years as a cardiologist, and you learn to do interventional cardiology, and you do a few hundred of those procedures. And hey presto, you're ready to do the TEER procedure. So that is obviously my silly way of saying that this is one of those don't try this at home, folks, procedures that requires a lot of skill and experience to perform safely. Now, if that sounds self-evident, well, Dr. Fiona told me that she has recently heard of a few non-specialist facilities who are offering TEER procedures, which she says terrifies her because, quote, animals are going to die. So enjoy this episode, learn from it so that you can have intelligent conversations with your clients and then refer them to somebody who knows how to do it. All right, let's introduce our guests. Dr. Brad Gavigan and Dr. Fiona Myers are both cardiologists from the aptly named Veterinary Cardiologists Australia, right here in Brisbane, and they are the first ones to perform the TEER procedure in Australia, together with their colleague, Dr. Chris Lamb. So we're privileged to have them share their knowledge with us on this topic. Okay, that's it for my introduction. Enjoy. Dr. Brad Gavigan, Dr. Fiona Myers, thank you so much for joining us on the Vet Vault to talk about a very exciting topic.
Yeah, absolutely.
Thank you. Thanks for having us.
So I was thrilled the other day. I was scrolling the social media. I don't know where I saw it, but something popped up that you guys are fixing mitral valves. There's a procedure that we're finally fixing mitral valves, and I immediately got an email and said, please, can we talk about this because we need to know more about it. So please tell us more about, what's it called? TEER, T-E-E-R, right?
Yeah, that's right. Transcatheter edge-to-edge repair. So it's absolutely a game changer as far as veterinary cardiology is concerned because, as you know, myxomatous mitral valve disease is absolutely the most common disease that we see in our patients. And for some of those patients, it will become a life-limiting disease process. Ultimately, that mechanical dysfunction in the valve is one which we haven't been able to effectively address, except by Dr. Uechi, the Japanese surgeon who has been offering open heart surgery via cardiopulmonary bypass now. He's really the only surgeon globally who has had any success in mitral valve repair. And of course, in human patients, mitral valve repair is the gold standard. But for a number of reasons, it is technically challenging in small animals and unavailable as well. So this procedure, this transcatheter edge-to-edge repair, is genuinely a game changer, which allows a reparative technique to be performed on patients who otherwise wouldn't have access or wouldn't be eligible to have a more definitive corrective intervention.
That's so cool. So can you talk me through the basics of what the procedure looks like? I'm obviously not going to, this is not a podcast to teach you how to do the TEER procedure, but just to give us a bit of an overview of what you're doing.
Yeah, I guess the procedure starts really with choosing the right candidate. Like a lot of procedures, the procedure has to match the patient. And in this case, we're looking at B2 or C patients. So the B2s are patients that have an enlarged heart, but not yet in heart failure. So typically they'll be on pimobendan. The stage C, we prefer probably ones that have early congestive heart failure, not cases that have where the heart has been damaged over a very long period of time, because they obviously still have to get through a procedure.
Yeah.
So once we select the patient, and there's the V clamp looks a little bit like two sort of corporal stripes, I guess, two V's.
Okay.
And those V's, ultimately, you have to have a V above the valve and a V below the valve, and you pull those together and it works like a clip, just like a paper clip over the valve. And so the part of the valve that is the most dysfunctional and leaking becomes held in place, and that markedly reduces the leak. And so to get to that point, the first thing would be to have the dog in theatre. It's a hybrid procedure, so there is a little bit of surgery involved. Most of our procedures that we do are all done via a vein or an artery, whereas this one's a little bit different. So we'd have the patient in right lateral recumbency and perform a small incision that lines up over the apex of the left ventricle. And so that incision might be 5 or 6 centimetres in length. And then we localise the very tip of the heart, and using a combination of transesophageal 3D ultrasound and fluoroscopic guidance, we pass a catheter through the very tip of the apex of the left ventricle, and that catheter carries the clip. And to enter the heart, we put a purse string suture in, and the heart is surprisingly robust. So during placement of the purse string, and even, been a cardiologist for a couple of decades, and I must admit both myself and Fiona find it very exciting, that we have that sort of access to the heart in a very safe way. And so we put a purse string suture in, put the catheter in through there, and then place the device under guidance. And we can move the device around to the optimum site. So with the 3D ultrasound, we can look at where the device is and then adjust it accordingly until we attenuate the majority of the mitral valve leak that's occurring. And then we place the device, detach it, pull the catheter out, and tie off the purse string, and we're done.
Wow. That's so cool. So are you working endoscopically? Your initial, like your chest wall incision. So first of all, it is an intrathoracic procedure. So you're obviously ventilating and stuff, but you're losing pressure in the thoracic cavity as soon as you go in, right?
Yeah, absolutely. So it's remarkably non-surgical for cardiologists, where we're doing interventional cardiology, which is exactly that, non-surgical cardiology. We, as Brad said, we access all of our other procedures are done via peripheral vessels, so we end up placing sutures. And it felt initially like this would be something that is quite different, but the reality of it is it's a very small incision in the chest wall directly over the apex. There's no packing lungs out of the way or anything like that with a more extensive thoracotomy. You're literally exposing the epicardium exactly where you want to stick the catheter. And then the rest is just done using fluoroscopic guidance and transesophageal three-dimensional. So by putting in what looks like an endoscope down the esophagus, but actually has an ultrasound probe on the end of it, we're able to image in 3 dimensions the heart, much like you see those 3D echoes of hearts and babies that people have during pregnancy. Exactly the same sort of technology, but we're looking at the heart through the esophagus from above. And so we can then see the device in the way that it's deployed really accurately. So none of it is us directly visualising the mitral valve in a surgical way. It's all indirect. And so for that reason, that's why there is such reduced post-operative morbidity, and the mortality rate is trivial with this procedure for that very reason.
And then when you're actually entering the heart, you said you go in through the ventricular wall. And is it just a catheter that goes in, or do you actually cut the heart? Does the device just pop itself in there?
Yeah, so we place a purse string suture in the epicardium, and then in the centre of that purse string suture, we progressively insert an 18-gauge needle with a guide wire, and then replace that along the guide wire with a large 14 French introducer that has a flange on the end. And so then you have access. Essentially, it's a big straw going to the apex, but the purse string allows you to prevent any bleeding around the straw, around the catheter. And then the device itself is collapsible, so it's like an umbrella type device. So when it's collapsed, you insert it through the catheter, and when it pops out the end of the catheter in the right place, then it forms its paperclip shape, so that you can then grasp the valve and pull it back into its paperclip formation.
What are the V's made of? The thing that stays in there, is it what's the material that it's made of?
Yeah, it's a medical grade metal, and then it's covered. It's got little barbs on it, so it's pretty aggressive. It grips on, but then it also has a material aspect to it as well, which is facilitates endothelialization and anchoring it in place beyond the actual mechanical anchor that's created. The biological response to it will help seal it in place.
Wow. So I'm trying to picture what it actually does to the valve. So and correct me if it's a wrong understanding, but I've always visualized an old rotten mitral valve as bumpy. Like it becomes, I always explain to clients, instead of a nice smooth valve that shuts, you have lumps and bumps and it's all deformed, and that's why it leaves gaps in between. So does this thing go over that and squish that, or just creates a smooth surface, or how does it actually fix the leak?
Yeah, so probably the best way to think of it is the valve, instead of it being like two doors closing, it's like two doors that keep swinging inwards and prolapsing and allowing blood to go past the edges of the valve. And so if we put a clip like this across the valve, basically it has the doors stop where they're supposed to stop. And so it prevents that door swinging the wrong way, basically. And there's a similar device called a mitral clip that's been used in people now for about 15 years, and there's over 150,000 people have had a mitral clip. In the canine world, it's probably worldwide, there's probably been 90 or 100 dogs have this procedure. The number one person doing it in the world is Dr. Chris Orton in Colorado, and he's helped develop the technique. And, he's published a paper where he looked at 40 dogs, and 38 of those dogs had procedural success where the leak was markedly resolved, and the other 2 of the 40 didn't die intraoperatively. It was more just a difficulty in placing the procedure. So there's yet to be any published deaths using this technique. That will come over time. Obviously, with time comes the outliers, and that will happen. But I think the criteria for success is you would certainly want to be a cardiologist first, and then the second is have a lot of experience at other cardiac interventions so that you know your way around the heart. It's certainly, we'd consider it a challenging procedure, but very doable. It's literally described as a safe procedure now because of the amount that have been done successfully.
Okay, but it's going to remain the domain of specialists, right? It's not, in 10 years' time, we're not going to be doing TIA procedures in GP practice when the equipment gets better.
No, absolutely. This is absolutely a very fine skill set. Like Brett said, it's very doable, but the background skill set that's necessary to get to the point where it's doable is extensive. As Brett said, it's not just even being cardiologist, it's having a heavy interventional caseload and familiarity that makes it an achievable procedure. In that regard, it's much like in human medicine, I guess. In human medicine, you don't just become a cardiologist, you become an electrophysiological cardiologist or a surgical cardiologist or a pediatric cardiologist. And this is one of these subgroups of cardiology. Not all cardiologists will do this procedure. And there's good reason for that. That it is a very fine-tuned skill set that does require you to have had a really heavy interventional background for it to be a successful procedure.
I'm going to interrupt you for a second to tell you about a couple of things that's new with the VetVault, and then we'll get straight back to our episode with Dr. Fiona and Dr. Brad. Now, I had a conversation with somebody I know fairly well and who is an avid listener of the podcast, who, when I asked her about, do you listen to the subscriber-only clinical podcasts, she said, oh, I didn't know that you had a separate clinical stream. And I was like, if you listen to the podcasts, how have you not heard the ads? I feel like I go on and on and on about it. Clearly not enough. So just to be clear again, we have separate clinical subscriber-only podcasts where I speak to specialists about all of my questions and all of their pro tips and what's new and what you need to review about clinical practice. Exactly like this one that you're going to listen to right now. In fact, this one is taken from the clinical stream. The difference is that we have more than 500 episodes in small animal medicine, surgery, and emergency and critical care, including awesome show notes that you can refer back to on a searchable database, which has become an entire reference library in its own right. So if you enjoy the clinical episodes you listen to on here on the free podcast, I want to guarantee that you're going to love what we have for you on the subscriber space. Go and check it out now at vvn.supercast.com. That's VVN for VetVault Network.supercast.com. I'll put the link for you in the show description. Then we have a brand new, this is exciting news, a brand new advanced surgery podcast that is separate to the other three, which we have made to be a guide for anybody who is doing a surgical internship, residency, surgical memberships, or any practicing veterinarian who is serious about their surgery. The goal of this podcast is to give you a deep core fundamental understanding of what you do in surgery. So it's not a practical how to cut guide. It is a understand what you're doing and understand best practices for better outcomes and to make you a better surgeon. I'll put the links to all of these in the show description. That's right there on your phone where you're listening now. If you scroll through all the text there, there'll be links that you can click that will take you to our GP level continuing education podcast, which by the way are now race approved. So you can get CE points for them as well. And to A Cut Above, which is the name of the Advanced Surgery podcast. Okay, back to Dr. Fiona and Dr. Brad and fixing heart valves. And is this the only repairing or fixing of the mitral valve that we do in veterinary science? I was aware, and I actually never followed up, of the Royal College doing something to mitral valves as well. Is this what they're doing, or is there a different procedure out there as well?
Yeah, there's two procedures. So there's this procedure which involves not stopping the heart, not putting the patient on pump, and then there's the mitral valve repair. So Dr. Uichi in Japan has pioneered an open heart approach, and that procedure there's attempts all around the world to try and reproduce his work, and he's a very generous and active teacher. So he goes around the world, including Sydney University, looking to do that procedure and hand on that skill set as best he can. And I guess one of the issues is that it is very difficult for other surgeons to reproduce his success rate. So most of the success rate with that procedure involves him doing it or being a part of the procedure. And that procedure certainly will carry significant risk because of the pump. Having a 4-kilogram dog's heart circulation be artificially pumped around is, that's a technique that in the humans has been going since the 50s to refine it, whereas in veterinary world, it's a very complex procedure and has significant mortality and morbidity with that procedure. So two procedures. One is open heart, and this is, I guess for want of a better expression, a closed heart procedure. And the open heart procedure can deal with some more advanced mitral valve pathology. So there's some cases that are not suitable for a V-clamp or a TEER operation, but can have the open heart surgery. So they're not complete replacements for each other, but very different procedures.
Okay. So that sounds like that's not something that's going to be available to most of us to refer for an open heart valve replacement. Well, what about the TEER? You guys are the only ones in Australia doing it at the moment. Is that correct?
Yeah. And probably for the foreseeable future we will be, because it does require multiple cardiologists to have the sort of success that we're going to keep aiming for. For this particular procedure, there was myself, Brad, and our cardiologist, Chris Lamb, who was working the transesophageal three-dimensional echo. So it really is, it's absolutely a two hands on the device procedure, and then another cardiologist doing the imaging. And so really for it to be anything less than that, there'll be corner cutting. And so because of the gross lack of cardiologists in Australia, I think that it will be probably a long time before it will be offered to the same level of success anywhere else.
Okay. And what about for our international listeners? What's the availability like elsewhere?
Yeah, well, certainly it's becoming more other cardiology facilities, particularly in North America, who have cardiologists who currently do a high interventional caseload, such as Texas, Colorado, North Carolina. Places which have already got a very established interventional caseload are now adopting the procedure. So Texas A&M have got a long history of interventional cardiac success, and they started doing these procedures actually the same week as us. So it will become more available in North America. And as Brad said, Dr. Chris Orton of Colorado he's a cardiology surgeon, so his training is actually specialty surgery, but he's certainly the most globally known cardiothoracic surgeon in the veterinary industry, and he's really pioneered this technique because probably born out of his own frustration with the lack of success with open heart repair. And so he's really driven the success of this, or developed this device and adapted it from humans to veterinary patients. So Colorado have had the highest caseload go through their doors so far, but it will be something which is far more available globally as other interventional cardiologists take this up. But the long-term results of something, of course, that we don't yet have on, and that'll become clear over the next few years. But we're certainly very optimistic about its role in veterinary cardiology at the moment.
What about the UK and Europe? Is anybody doing it there yet?
I would be very surprised if the facilities in the UK which already do interventional cardiology aren't looking at this procedure, and they haven't already started enrolling patients. I suspect that will be offered soon.
Okay, great.
Certainly very skilled interventionalists in Germany and France and in Spain. And so I would suspect that a bit like we are in Australia at the moment, there's cardiac groups that are just beginning to start doing this procedure. Yeah, we know there's groups in South Korea and other Asian countries that are looking to commence it as well.
All right. So in terms of us at GP level having conversations with clients about it and selecting the right patient, so you said already it's going to be B2 or C. So there's physical changes to the heart. So basically when I hear that, when I do my vaccination and I hear that murmur and the dog has a scan and they go, yep, there's a mitral valve changes but no chamber enlargement yet, that's not my candidate. Is there no benefit of getting in ahead of the game and saying, well, like, why not do it sooner the better?
That's a really good question, Hugh. So B1 mitral valve disease, those dogs, a significant portion of them are going to live to be little old dogs and die from a different disease. So stage B1 dogs are not the ones that stand to benefit from this procedure. With regards stage B2 versus C dogs, there is a bit of a crossover there because, of course, once a patient has developed congestion and they are a stage C dog, then we know they have a finite life expectancy. Those patients have 6 to 12 months to live, and so an interventional procedure which can structurally correct the valve is potentially life-saving for those patients. But some of those patients will have a valve morphology which is no longer amenable to transcatheter edge-to-edge repair, whereas dogs with stage B2 disease who have very advanced cardiac remodelling who have not yet developed congestive heart failure, those patients, we're starting to sense that those patients probably have a higher frequency of valve morphology, which is amenable to the technique. So having said that, we're not looking at early stage B2 patients even, because B2 can be a stage of disease for which a patient can be in for several years. So we don't want to do the procedure on a patient who isn't looking down the barrel of a bad prognosis. We want to do it on a patient who has foreseeable life shortening as a result of their heart disease, where this procedure will change that prognosis for them. So advanced B2 dogs and stage C dogs with the correct valvular morphology are the patients who stand to benefit from this procedure.
Okay, so there's almost like the little Goldilocks period where the animal has proven that, yes, this is going to be a problem for me, but it's not that far advanced where you go, well, things are pretty ruined in there. You can't go for it. Yeah. Okay.
Yeah, that's what Chris Orton and our experience has been, is that the more we look at these valves, it seems to be emergent that there's value in sort of looking at them earlier and being proactive rather than reactionary.
Mm-hmm. Okay, so for us as GP vets planning this, let's say I have I know my patient has a murmur, it has mitral valve disease, and now it's on the radar that there is potentially a fix down the line. Do we say to our clients, well, come in for us, or go to your cardiologist or somebody for a 6-monthly scan, and when we hit that stage, when we go, okay, crap, now we're starting getting chamber enlargement, rather than saying, well, let's wait until you start seeing signs of congestive heart failure, and then saying, okay, well, now go see Brad and Fiona. Or how do we plan this? Let's say my dog gets sick. How am I going to stop it from dying of heart failure?
We have a lot of inquiries from interstate veterinarians, and our advice to them is to have a cardiologist. If the first scan was not done by a cardiologist, certainly have the next one done by a cardiologist, that we'll work with that cardiologist in terms of discussing what information we need from the views, because the routine exam, even by a cardiologist, won't necessarily cover what we require in terms of understanding mitral valve morphology for patient selection. So we will send them a list of criteria, and then they can send the images to us, and then we start to narrow down the process of whether that patient is a suitable candidate.
Okay. So if you say cardiologist, that includes, let's say I had a medicine person scan my dog, that you say still not, go find a cardiologist that you guys will work with. Let's say I'm in Perth, go see a cardiologist there and they'll chat to you guys. You'll say to them, here's the scans I need, that's the views, that's what we're looking at, and to get all the right info. Does that make sense?
Yeah, because what we don't want is a patient coming from Perth or Adelaide, and then we assess them on site just the day before the procedure and find something unexpected. And so, yeah, a cardiologist certainly has to be involved in the process. Yeah.
Okay. In terms of setting expectations for us as the primary caring vets, my conversation when we started, I think you alluded to it earlier, but when I see a patient that comes in for the first bout of congestive heart failure, and you go, okay, I will say to people, yep, we're going to manage this. We're going to buy your animal healthy time, but it's going to be the thing that's going to kill it, probably, unless something tragic happens in the next 6 months. Does this change that conversation potentially? And you said we don't know the long-term outcomes, but does it mean that you can actually change the conversation and say, well, there's something I could do to fix it?
Absolutely. And I think for these patients, there's not any ambiguity that this clip significantly reduces the leak in the mitral valve. You know, the little patient that we did just recently went from being in heart failure to discontinuing diuretics the day of the procedure. You know,
The day of the procedure?
The day of the procedure, and the mitral murmur disappeared, you know, because what the clip does is it not just seals together the valve, but it draws the annulus into a smaller dimension as well. So even though the valve itself is raggedy and nasty, it seals better in a smaller heart. You know, so there's no ambiguity that the procedure itself is very effective at reducing the leak in the mitral valve. What we don't know yet is how that translates to long-term outcome. You know, if we're talking purely about mitral regurgitation, wow, it's amazing, you know. But what we don't have in a very scientific way is data yet that says that these dogs do live longer as a result of this. You know, because although it's something that we don't anticipate and there's no case reports even of the clip coming loose and creating death by a different means. You know, we don't have that data yet.
Yeah.
So we're very optimistic in that we can see the mechanical response to the device is extraordinary, but how that translates in a clinical patient, which is something as scientists we have to be very cognizant of, that we don't yet have the data to support the translation to survival times.
So what's the longest living patient? Do you, like the Colorado team, how long have people been doing this procedure for?
Well, it's been going in Colorado now for 3 years.
3 years.
In human patients, and that's probably the best way to answer that question, is to look to the human field, because in human patients, the gold standard for mitral valve insufficiency is cardiopulmonary bypass and open heart repair. But of course, there are a whole bunch of humans who aren't eligible for cardiopulmonary bypass because of comorbid conditions. And so for those humans amongst us who can't have definitive mitral valve repair under cardiopulmonary bypass, they've been having for the last 18 years a MitraClip, which is this device in humans. And in people, it has well and truly been established that the Mitral creates an extension in survival time above medical therapy alone. So while we don't have the data in dogs, we do have the data in people, and people are absolutely at an advantage by having the structural repair to the valve via mitral clip as opposed to just medical therapy. So everything is looking very, very much like we'll have that same data in dogs.
Wow. The practical aspects in Australia, obviously, cost is always a discussion we have to have. I won't ask you for direct pricing, but like compared to a TPLO or another big surgery or something, this is obviously a very specialized procedure. How viable is it for your average client, price-wise?
Yeah, I think there's a couple of parts to the question. Firstly, because it's an acquired disease, insurance is a big player in this, and we know that the experience already with the first case that we've done is the insurance company are absolutely involved in helping out with the costs. So I think that will be a big help. The open heart procedures will range from 50 to 70,000. This procedure will range from 30 to 35,000 in the average patient. So there does seem to be no shortage of people being enthusiastic for it, but obviously, you know, there's also going to be a group of people that is going to be beyond what is reasonable for their circumstance. And yeah, our goal is to absolutely provide the very best medical care for those patients, and then for other clients that are interested in this procedure, then this obviously becomes a viable alternative. Yeah.
I mean, in terms of if you get because you do get the dogs at a relatively early age, 8, 9 years old, start developing congestive heart failure. If you go, well, that's potentially going to give them years extra, then it sounds very, very sensible. I think it's doable.
Absolutely. Without sounding like a salesperson, this is something I would absolutely do for my own dog.
How many cavies are you guys going to start seeing?
We already see a lot of cavies, unfortunately.
Yeah, I suppose. I'm just, when you said about insurance, I wonder if there'll be a Cavalier King Charles exclusion clause. You cannot get a tear done for your cavity. All right. Well, what am I missing out on? Because to me, this was I just wanted to do an introduction, basically get the message out there that this thing exists and there is another. As I said, it's really, I love stuff like this where the conversation I've been having with clients for 20 years suddenly changes in any field of veterinary medicine. And this sounds like one of those pivotal moments.
Yeah, and I think for us as cardiologists, you could have heard a pin drop in the room when the clip was placed and we put the colour Doppler on. And to be honest, there was very close to no mitral flow. Wow. And for the heart murmur to go from grade 5 to no murmur on the same day, and the heart physically during the operation, we can measure it shrinking down and getting smaller. So that happens within a matter of minutes. Blood pressure changes, cardiac output changes. So for us, this is a career-changing procedure, and that we've spent, between 30 to 40 years telling the same story to people, and now we have a different narrative. And Dr. Chris Orton, who's been the leader in cardiothoracic surgery for the last 3 decades, this is now it's almost his legacy, because he's gone from the trials and tribulations and late nights of hoping his heart patients would survive cardiopulmonary bypass to now he does 1 or 2 of these per week. This has been transformative for him and for us, and I think obviously for general practitioners too. It's nice for them to have a different story, and the procedure and the sort of question and answer that go along with the procedure. All of this is on our website, so clients and vets have portals there where they can click on and read about it, and that'll probably answer the majority of their questions. And then, we're really only an email away to answer any other questions.
I'm amazed that what you said, you can literally see the chamber shrinking while you're doing it. So that's not a permanent stretch. Chamber enlargement in congestive heart failure, is it almost like an overinflated balloon and you let a bit of air out and it shrinks back down again? I always assumed that once that atrium is big and flabby, it's big and flabby for life.
Oh, I love this stuff, Hugh. You could get me started on this patho and I could go forever. But essentially, we talk about the heart dilating, and that's just too crude a terminology to use. It's a very active process, reactionary process to the hemodynamic changes. And this is happening in reverse. So the heart is very actively, certainly there's initial reduction in the regurgitant volume, which allows the heart to become smaller immediately. And the heart very proactively remodels. And that's the wonderful thing about this procedure, that while the clip is reducing the size of the leak, it's also, as I said, reducing the size of the annulus. So the valve continues to age, but it just fits better in a smaller heart. So it seals better, it works better as well, despite the clip. So it is truly an extraordinary response to what is a very significant change in the dog's heart.
Jeez. I love what you're saying, Brad, about for you guys, because as you were saying that, because you've spent your entire career fighting this thing and just palliating, really, and getting better and better at palliating. And now there's this major leap where you go, well, finally we can freaking do something about it and not just fight around the edges almost. What a paradigm shift for you. It's amazing.
Yeah, and clients have, been for decades saying, because people are obviously aware, a lot of people have a relative that's had valve repair and sometimes this exact valve, and, for literally decades, we've had to say, actually, no, we don't have a procedure. So that's really changed the conversation for us. And so it's an exciting time to be a cardiologist at the moment.
How big were the high fives once you got your gloves off after surgery when you did your little patient?
Yeah, I think we kind of looked at each other and just thought, wow, this is so doable. And, procedurally, we felt very comfortable with it as well. While it was challenging, I think we've come along at a very good time where 150,000 people have had the device that's been developed over that time, and then it's been further developed for our veterinary patients, and then someone like Dr. Chris Orton, who's taken this on and collaborated with the device engineers and manufacturers. So we feel like we've come along at exactly the right time, sort of after the first or the second publication has come out to show that this is a safe procedure. So it's a procedure that, if Dr. Chris Orton was asked if it's experimentally, he's almost a bit bristly, because it's certainly not. It's a routine procedure now for cardiologists that are interventional cardiologists and have a skill set in this area. There's potential for this to be just something that we do every month, and that's our plan.
Okay. Wow. Is there anything I'm not asking?
No, I think you've probably covered everything that we think of to ask. But I think absolutely when you hear a murmur in a dog, the first thing should always be, let's find out what it is, because then we can know whether or not we need to worry about it or not, and how to deal with it moving forward. So identification of a murmur should always just be a question then of what's creating the murmur. And then we can answer all the questions that come from that once we've had a diagnostic echocardiogram. And for those patients, then they'll be led down a pathway which will be optimised for them. And if it turns out that murmur that was picked up 3 years ago it was mitral valve disease, then we'll be seeing that dog back for its recheck and its recheck and its recheck. And then if they look like they're at risk for congestive heart failure and they're a candidate for this procedure, they'll be well positioned to have a procedure performed and find the optimal pathway forward for that patient. So I think that's really the take-home message, I guess, for general practitioners is when you hear a murmur, let's know what that murmur is first. And once we know what it is, then the path will become clear for that patient. And if this is what's involved for that animal, then we'll know about it.
Yeah, this adds a different level of motivation for being on top of exactly what's happening, because it can, as a GP practitioner, your heart cases could feel almost hopeless to the extent where you go, well, it's got a murmur, let's see what happens. Yep, now it's got heart failure. There's some frusemide. Oh, it's getting worse. There's some, without referring it for a cardiologist workup. You sort of manage it medically based on clinical science. It can be tempting to do that, but with this, there's a very good reason to say, okay, this is why we need to know exactly what's happening to your patients, because we have this potential fix and we don't want to miss our window of opportunity.
Yeah, absolutely. And I think, that's always true, because even there'll be some little, if we're betting people, we'll say that most small breed age dogs with a left apical systolic murmur will have myxomatous mitral valve disease, and that's a safe bet. But some of them won't. Some of them will have at age 7 a PDA that's never been picked up before, and that too is a curable disease. But we need to not just treat with frusemide. We need to know what the underlying problem is. And so the optimal path will always be to get a definitive diagnosis. And then we can know whether or not frusemide is all that's necessary for a patient, or whether or not there's an option for a transcatheter edge-to-edge repair, or a PDA occlusion, or pulmonic stenosis balloon procedure, or if there's something better than just palliation once a patient becomes symptomatic.
Okay, Brad, Fiona, I can't wait to get this out there to the rest of the vet world, and I can't wait to send my first patient to you for this. I'm going to be looking out for the right patients from now on. So thank you so much for sharing this with us, and for taking the time to talk to us, and for doing the work to getting this out to Australians. It's amazing. Thank you. Before you disappear, I wanted to tell you about our new weekly newsletter. I speak to so many interesting people and learn so many new things while making the podcast. So I thought I'd create a little summary each week of the stuff that stood out for me. We call it the Vet Vault 321, and it consists of, firstly, 3 clinical pearls. These are 3 things that I've taken away from the clinical podcast episodes. My light bulb moments, the penny dropping, any new facts, and the stuff that we need to know to make all the other pieces fit. Then, 2 other things. These could be quotes, links, movies, books, a podcast highlight, anything that I've come across outside of clinical vetting that I think you might find interesting. And then 1 thing to think about. I'll share something that I'm pondering, usually based on something that I've read or heard, but sometimes it'll be just my own musings or rants. The goal of this format is that you can spend just 2 to 3 minutes on the clinical stuff and move right along if that's all that you're after. But if you're looking for content that is more nourishing than cat videos or doom scrolling, then our 2 other things should send you in the right direction. And then something extra for when you feel like a slightly longer read. If you'd like to get these in your inbox each week, then subscribe by following the newsletter link in the show description wherever you're listening to this. It's free, I think it's useful, it's fun, and it's easy to unsubscribe if it's not for you. Okay, we'll see you next time.